My name is Sheiladen Aquino. I'm the clinical lead speech and language therapist here in Commonwealth, a part of the Bridgend Integrated Community Services. Well, this project, we developed it initially because this was post-pandemic, wherein we have a long waiting list after the pandemic, and at the same time, we also have a higher need for our people in the community who are most vulnerable, and these are our residents in care homes. So we wanted to find a way so that we can provide better service for them, but at the same time, we're thinking, the staff are also tired, they're exhausted during the pandemic. How can we make it work to provide better service, but at the same time sustain the energy of our workforce so that we can actually make sure that our service is sustainable? So I actually approached one of my colleagues. He's a clinical lead pharmacist at First Point. And I asked him the same question: how can we actually provide better service? So as speech and language therapist, one of our expertise is to provide assessment and intervention for people who have swallowing difficulties. So our residents in care homes, they're frail, they have difficulties eating and drinking because of the weakness of their mouth, their muscles of their lips and tongue. But at the same time, our colleagues in pharmacy also would have difficulties with making sure that their medications are actually taken and maintained, particularly for those residents who have swallowing difficulties, who can't swallow their medications on time because of the difficulties that they have. And so we were thinking, we are a part of this community integrated team. What if we can actually develop a new way of working, wherein we're going to provide a service as a team, a joint session together? And so we then challenged ourselves, are we the only professions that can actually provide this? And so I said, well, one of the partners that we closely work with are dietetics. And so I approached dietetics department as well. And surprisingly so, they have the same problem. And so we said, well, if we are having the same problems, we have also the shared risk. So if we can develop a solution together, then perhaps we can eliminate all the long waiting lists that we have. We can improve services by improving communication with each other. And at the same time, when we provide service as a joint service, then we can improve the quality of the service we provide. So we are an integrated team, and we're so lucky that we're housed under the Bridgend integrated model. So we set up a pathway of care wherein there's only one point of access for referral for the three professionals, so that instead of them making 3 referrals, they just need to use 1 referral. Instead of them having waiting lists for 3 professions, they don't even need to wait that long because of the efficiency of care that we've provided. And at the same time, at the end, instead of them receiving 3 disjointed reports, it's just 1 report with all integrated recommendations that has been provided by all 3 of us in 1 single session. So instead of them attending 3 separate sessions, it's just 1 session for all of us. So we approached partners in the community, our care home partners, and we have 4 care home partners at first instance for our pilot. And it was a successful pilot. So what we've done at first instance is that it is developed with them. So it's co-produced and co-designed not only by the 3 professionals, but also our partners in the community. So from start, how to develop the referral form, how to actually communicate and engage with them, how to set up the service, and how to communicate with them in the end and document. So all of this pathway are co-designed with them. And we found that it's hard to develop a new service, how much more develop it with 3 different professionals. So we actually asked Vivan Exemplar. So the Vivan Commission was very supportive, and we become a Vivan Exemplar. And at the same time, we tapped on Tech Camry to help us as well, because the only way for us to move this forward is for us to use digital technology. So that's how we set it up in the first place. This service can be accessed by everyone. It's an open referral. What we've done is that we provide training for all the care homes now, because we rolled it out across all care homes in Bridgend already after the pilot. And so all of them can access with just one referral form. So that they can access all three disciplines. And we triage as a multidisciplinary team as well. So we identify who are the most vulnerable, and we see them immediately. And after accessing, we then book intervention and session. So how we provide service now is that instead of us going to them, we train our community partners, the staff in care homes, and these staff know the residents well. The residents trust them. They have this relationship. So instead of another person going there and, say for me, touching their throat and another person that they are not familiar with, they interact with the people that they trust, so that we can actually have a real picture of how they behave when they're eating and drinking, how they behave when they take their medications. So we provide the assessment remotely. So all clinicians actually be in their clinics, in their hospitals. So it also facilitates for us to be more efficient with our caseload. But at the same time, the residents are more relaxed. They're in the care home. They don't need to travel, because most of the time when they travel to their appointment, by the time they arrive at the hospital setting, they're tired. And we can't really find a really good picture when we do an assessment. So they're there in the care homes with the people that they trust, and we conduct the assessment that way. We also, because it's remote, we also welcome family members. They can be there in the care homes, or if family members are away, then they can attend virtually as well. So as much as possible, it's all inclusive, it's seamless care, but at the same time, it's not just seamless care for health professionals, but also inclusive for families, inclusive of people in the communities, and respectful for residents, so that they'll be relaxed, they'll be comfortable as well. And once we actually do the assessment, we then make sure that whatever questions that the family has, that the carers have, then these would be addressed too during that session, because all three of us are there. We're able to address whatever concerns that they have, if there's any medication issues that they have, swallowing issues, or nutrition, hydration issues that they have. It's all addressed in one single appointment. And at the end, we just make sure that all information is given to them. We try our best to send the information as quickly as possible. And again, we use this digitally. All of this was able to, I guess, we were able to do this seamlessly because we also have a really robust training system. So we train not only information to care staff so that they can they know how to do the assessment properly, but we also do like a hands-on training with them. So during the initial phases, somebody from our team would be there in the care homes to provide support for them. Somebody from Tech Camry will be there as well to do an induction for the technology that we're using. So to make sure that everyone will be supported for this new way of working. And I guess at the end, we just want to make sure too that everyone is safe in their practice. So we make sure that the policies are in place, service agreements are up to date as well, so that it's not just a new way of working, but also making sure that everyone is practicing at their standards and everyone's comfortable and safe in their practice. We were very ambitious when we set up this project. We were thinking, might as well use the during that time, it was newly published Quintuple International Health Improvement Goals. So it was published with WHO during that time. And we were thinking that we might as well target these 5. So one is better experience for our residents. Second is better clinical outcomes. Third is costings, of course. And the 2 new ones are, fourth one would be better quality of service through sustained workforce. And the fifth one is equitable care for all. And we are really concerned about the fifth one because these are elderly population, high risk and very vulnerable, and we're using digital health. So we're trying our best to actually target as much of this five as possible. And we're happy to report that we have. During our pilot, we are able to show that we've improved the experience of our residents and the care home partners that we have. So we reduced the waiting list to 70%. So they're being seen faster, and not only that, they're being seen by all three professionals in seamless care, in integrated way, and they don't need to travel as much and disrupt their routine in life. So that's one. And second is that we really focused on the clinical outcomes, on their quality of life. We want to make sure that our input is not only medical, but really want to make sure that our input is more impactful in the day-to-day on how these residents are actually living. So we focused on three key measures for quality of life. That's activity, participation, and well-being. And most of the residents are, as I said, very frail, and their quality of life, as expected, usually goes down over time. However, when we compared before and after, we actually see not only maintenance of quality of life, but actually an increase of quality of life after the intervention that we have. And the third one, cost. Initially, we were thinking that this might not actually benefit when it comes to cost, but we actually were able to show that because one, we're using remote services. We're able to cut down on travel costs and time for clinicians as well because we're able to see more people. Two, our capacity has increased in the community because of the streamline that we have. So at the end of the year, we're able to see 100 more community patients because of this streamlined service. And third is that because we're able to see them promptly, we're able to put things in place so that if they do exacerbate, then we have a plan, anticipatory care plan for them, for everyone, the family, the care home staff, to know what they're going to do if these things happen. Then we're able to prevent unnecessary hospital admission, that our residents don't really want to be in hospital, but we're able to put that in place early. And so our outcome showed that we're able to save 360 days of hospital admission for our care home residents. And these are from our pilots alone, only from 4 care home partners. And the fourth one would be our workforce. So we are very concerned and very aware that the workforce in health and social care has gone down significantly during the pandemic because of the stressors that's added to these roles. And so what we've done is that we've collated pre and post questionnaires on how they feel and their level of confidence before and after the pilot. And at the same time, we've done some interviews as well with our key stakeholders. And what we've actually seen is that they've improved their confidence on how to manage high-risk assessments like these remotely, how to manage their residents. But also, I remember one of the interviews that we had was that one of the nurses said that she's proud to be a nurse, and she is proud to be, it elevated almost her humanity because she's able to connect more with her residents. So that was really impactful for us. And also, when it comes to workforce, working with my colleagues, again, we're so lucky to be in an integrated service here in Bridgend, wherein this is a way for us to fully understand and live how integrated working can really benefit our residents. So I needed to shed some of my professional boundaries so that I can work alongside my dietetics and pharmacy colleagues. And by doing that, I believe that we started a way to break the silos, in our own individual practice. And I learned so much about dietetics and how they work with pharmacy, and I felt really supported with my colleagues. These are high risk patients as well, needing really intensive need, to meet their intensive need and complex needs. But because I have my colleagues, I feel really confident that my recommendations are sound, that I am providing the best care that I have. So I feel really, I feel accomplished as speech and language therapist working alongside my colleagues. And lastly, the fifth goal that we have in the quintuple aims is health equity. So again, we were really concerned of using digital health in an elderly population in, I guess, a nursing home institution. But what we found when we actually collated the data is that 80% of all the referrals that came to us was able to complete the whole pathway from start to end using the digital pathway. Now, I agree, digital is not for everyone. It's one of the tools that we can use to provide better service. And so the 20%, I acknowledge that we need face-to-face, and we still provide face-to-face service for them. But 80% is actually high to showcase that using digital technology is not impossible for elderly population, for institutions. It's really just having, again, really good partners. Tech Camry was brilliant with helping us to set it all up and providing, I guess, a different way of accepting that technology is nothing scary, but it can actually help us so that we can provide better service, and at the same time, it will help us to be more safe in our practice as well. So those are our 5 quintuple aims. One thing that I've learned from doing this project is a change in my leadership style. In the past, I would always lead in front, pull people with me, and then I just charge forward. But with this project, I realized that leadership is not only by one person. Leadership is shared leadership in an integrated care service, wherein part of my team displayed so much motivation, so much vision that we actually help each other. And leadership is more shared. There's shared accountability, and what I found is that our strengths is actually more highlighted, knowing that there's no clear boundaries on who you are and what you're supposed to be doing. But the shared strength comes from a communal way of, of leadership. Pilot now is rolled out across Bridgend. However, our colleagues in dietetics and my colleagues in speech and language therapy from Merthyr and Rhonda are now rolling it out in their areas as well. So it will be an all CONTAF, all health board service now, and they're rolling it out for the whole health board. This new way of working is helping the most vulnerable in the community, our residents in care homes. We are able to show that it stops unnecessary hospital admission, that it's a prudent way of working so that we won't access additional services like ambulance, and we didn't really need additional services. We maximize the current service that we have from dietetics, speech and language therapy, and pharmacy. And at the same time, we're able to showcase that digital technology is able to show health equity even for the most vulnerable, our elderly in the community. And this is made possible only because it's a way for us to use integrated model in the community wherein it's seamless way of providing services, and at the same time we elevate the quality of life of our residents in care homes.